ventilatory rehab, if we have those 7 goals that we try to have for a successful pulmonary ventilatory rehab program.
Increase chest expansion.
Yep, so like number 1. And then when I do the technique, we're also going to hit number 2 there. So increased inspiratory capacity. So it's going to kind of hit those 2 goals. So with this lab, we're going to be kind of following what these recommendations are, so we can kind of see where these different techniques fit in as far as this rehab program goes. But so for the first one, so based on what we talked about in lecture, we talked about what the different planes of movement are, different parts of the rib cage. So we're going to be really on that lower part of the rib cage. So based in lecture, we talked about what's the primary direction that part of the rib cage moves. Lateral and superior. Yep. So if I think about where I want my hands to go, it's going to be more lateral on the rib cage. My direction of pull or movement is going to be laterally, but also tractioning down. So the idea is I'm trying to create some length or mobility within the rib cage, and I'm going to use the respiratory cycle to kind of aid some of that mobilization technique. Okay. So my hands are going to be lateral rib cage. I'm going to follow her breathing cycle. As I ask her to breathe in, I'm going to ask her to breathe in and out, and I'm going to actually walk down her rib cage with my hands. While I'm doing that, my direction of pull is going to be in and down. So I'm pulling this way. You'll see the rib cage kind of move side to side. I try to keep my hands in contact with the skin as much as possible, but they're going to have to move a little bit. If you come across someone who has a really small rib cage and you've got big hands, you're probably not moving very much. But Bailey here has a larger rib cage, so and my hands are small, I can walk down a couple cycles. So I'm gonna show you how to do it, and then I'm gonna chop through it. That sound good? If you can't see, move. So I always, whenever I go to touch someone or look at any kind of breathing, I'm just gonna follow them for a couple cycles so they kind of get used to me being there, because it's really weird. Good. Good. Breathe in and out. In and out. And relax. Okay, so a couple things. So as she's breathing out, that's when I'm bringing her rib cage down. I then hold her there when she takes another breath in. Why might I do that?
Stretching.
Yeah, so I'm going to fixate some of the distal segments so then she can expand above. So it's a way to kind of mobilize those ribs separating. So we'll do one more time. So I'm going to have her take a deep breath in and out. Squeezing in and pulling down. Holding there. Breathe in and out. Breathe in and relax. Okay? So ideally I want to start a little higher because I am moving down. You want to avoid coming anteriorly. Why would I want to avoid coming anteriorly? Gonna mobilize cartilage. That's not really good, right? The most mobile segments we know are going to be xiphoid process or any of the anterior lateral distal part of the rib cage. So I really want to stay lateral. My hands, my fingers are staying together. I kind of keep a little bit cupped. If I have my hands just flat, my thumbs come off, I lose some of the control or some of the contact. So really holding here. You can hold here if you want. It's not comfortable for me. And then the last thing is that try to keep your elbows in. If you're coming here, then I'm just compressing and rocking back and forth, but I lose that traction down. Okay? So, kind of following the rib cage, and here and I will say you're taking up the slack, meaning you're just following it down, let it come all the way down, and you have to watch your patient when they're done breathing, when they finish exhaling. That's when you do that slight change. It's like you're signaling we're changing directions, and I want you to breathe in now. So that's kind of the practice point, is take up the slack, wait, and then help them time the breathing. Some people are going a little early for when someone's actually not done exhaling. You're going to confuse them. Okay? But I think overall, I think people kind of have the position. Any questions? So this would be a situation where you have one side of the rib cage that's moving and the other side's not. So what's a patient that might have that situation? Scoliosis? Sure. I was going stroke. But that works too. So first you have to make sure they have the mobility. Like, I'm not going to mechanically block someone if they can't breathe on that side because they have a fixed scoliosis. That's not really fair, right? So this is someone who has some ability to use that side. There might be someone who has a hemiplegia, and we talk about return comes proximally before distally. So let's say you're working with someone and they are just dense, like right upper extremity, lower extremity is not a lot of active movement, but could you do something? What's happening at the rib cage? Could we do something to kind of work on that? There's other situations you could use this with, but we're going to stick with more neuromuscular. Unless Karen, you have something to add? Nope? Okay. So the idea here is I'm going to have the same hand hold that I had for the rib mobs, except I'm just going to hold one side. And I'm actually physically going to mechanically block one side. So then Jared, if I have enough strength and leverage, he could really only use the other side. Theoretically, you can't completely block somebody. If for some reason I just am not strong enough, he's just too big, what's another position I can put it in that just mechanically blocks it?
Sideline.
Sideline, yeah. So this is a situation where you're in supine with them and you could work this technique a little bit. Okay, if you just pull your shirt up just a little bit. Okay. So the same thing here. I keep going on one side or the other. Remind me if I to switch, if I'm always my back to you guys. So same thing here. Pull hands. So if before we had our hands laterally, but here I'm just going to have my hand on one side. That's primarily going to block. I could keep two hands on and I could facilitate with the other hand. I'm going to first just demonstrate it where I'm just blocking one side, and then the second one I'll demonstrate where I'm actually blocking and then facilitating. Okay? Okay. Let's go ahead and breathe in. And out. Breathe in. And out. Breathe in. And out. So all I did is I followed his respiratory cycle. I let him breathe out all the way on one side, and then I just held that side there. So my hands are smaller, so I have to use different techniques. Some people with bigger hands can just use one. I also use my elbow at my side to actually help me kind of hold that there, just so I don't tire out, okay? So that would be just a block. If I want to facilitate on the other side, so breathe in and out. Blocking with my right hand, breathe in and out. What technique am I using? Yep, stretch. And out. Same as when we do the rib mobs, kind of you come down and in. It's the same thing I'm going to do here on this side. One more time. And out. Breathe in. And out. Sometimes it's hard because your hands are doing two different things. So give yourself some time to practice that. But let's go ahead and do that, segmental, and then we'll do facilitation. Timing, moving forward, is breathing with your patient, meaning adapting the pattern that they have so that you can help with your timing. So can I sideline or sitting? If we have him in supine, if we're trying to facilitate diaphragm, what position am I going to do? Is Billy going to look like this? Yep, so we can start hook lying, so can you go to hook lying? So that would be a start. Yep, so I would say that would be a place to be. Probably to teach this position, my first choice is side lying. And I'll kind of talk about why that is. So why would you do this with somebody? This is where you can ask your question now.
Well, my question is why you would diaphragmatic?
But which is better for a normal person? Yeah, so there's not that goes into like a whole nother discussion, but in general, if upper chest or diaphragm, it doesn't necessarily matter. I think if you're someone who is totally normal, healthy, functioning, and you are a more upper chest breather, you probably are a little bit more tightly wound of person. You probably are maybe a sprinter. You're someone who uses a lot of fast twitch muscles, and so you're probably predisposed to sprinting. Okay? If you have someone that's a little bit, in general, more laid back, someone who tends to be more of an endurance athlete, you'll see people tend to be a little bit more diaphragmatic breather. And so whether or not one causes the other, I don't necessarily know, but that would be kind of some conversation around that. why we would teach this with a patient is let's say Billy here primarily uses upper chest and his respiratory rate is really high and he's fatiguing and he has a cardiovascular impairment and I need to coordinate some of the muscles to support breathing a little bit more. So we look on like the ventilatory strategies, goals of rehab. The idea of being able to balance use of diaphragm and accessory muscles. So I need to use some diaphragm in order for everything to work more efficiently together. So I'm going to do the first one. I'll do it in side lying, so I'll go on this side. So if I can have you face that way. Do you want a pillow? Okay. So with this technique, it's going to be a scoop technique. Okay. So you're usually behind the patient if they're in side lying. Oh, you're good. And then I'm going to have one hand that's going to start pinky side down. Okay. And what's going to happen is that as Billy breathes, my hand's going to kind of pronate. And then as I follow him back in to breathe, I'm going to scoop and supinate. And so I'm kind of taking over a little bit what the abdominals do, that I'm giving some positive pressure or support for the diaphragm and helping guide to say, like, this is how you should use your diaphragm. You need to drop. It needs to come down and in. If he was really an upper chest breather, he would just, he would lock this here and just be moving here. So I really wouldn't see any movement if he was truly not using the diaphragm to breathe. Obviously, he uses the diaphragm to breathe or he wouldn't be here, but the idea that that's the pattern that he chooses to use, okay? So I'm gonna have one hand that's gonna be more along the belly button. I like a midline position. Judy likes an off midline position. It doesn't necessarily matter. It just depends on what feels most comfortable for you and for the patient. So if I'm down here, and like Karen said, or we mentioned earlier, you have to follow a couple cycles of breathing before you actually start to facilitate anything. So I'm right now keeping more of a cupped hand, not a flat hand. Keep a cupped hand. So thumbs squeezing in. Good. So I'm gonna breathe in and out. Breathe in and out. And as I come in, I'm scooping. I'm going this direction, coming up and underneath the diaphragm. And out. What's my sensory cue I'm using?
Breathing.
Breathing. So I'm modeling his rate, and I'm doing slow inhalation, slow exhalation. It's quiet. I could give cues if I want, saying like, breathe into my hand, breathe out. I tend to like to more breathe because it helps with my timing. But that would be just one way to facilitate diaphragm. The other thing I was adding after following and scooping is I was adding a little bit of a quick stretch. It's not a compression, but it's really, I follow the diaphragm all the way back up, and I can do just a slight supination that happens, and then I let the diaphragm come back out. Okay, I'll do it one more time. Okay, so just really slight and subtle, not chest compressions, right? Just really slight and subtle. So we'll contrast that then with upper chest. So positioning for upper chest. So if we wanted him more in hook lying to start, no. For diaphragm, to get more upper chest, what do you think? What?
Arms up.
Yeah, arms potentially up if someone can tolerate this position, great. We talked about some of those other modifications, so even just having his hands at his side supinated is better than hands on belly, okay? So release biasing him into this position. We could go as far as, could he get here if he had the range? Sure, you could try that. But for this case, the minimum thing I'll ask you to do is just going to be hands there. You could also, if you wanted to get more trunk, some more trunk opening or chest opening, what else could we just put behind him? Yeah, like a towel roll or something like that to just get more chest opening. And that's just going to make it easier for them to figure out how to use upper chest. So I would use this technique on someone who is that strong belly breather, who doesn't have any, right? Didn't you say, Chris, that you, yep. We're gonna try this on Chris later and see what happens. So the idea that I'm trying to get the rib cage to come in more, so this is that balancing diaphragm and accessory muscles. If I have some of the overuses diaphragm, I need them to balance with some type of upper chest movement too. This is why I choose to use that technique, okay? So I'm gonna show 2 different hands. One of them is gonna be 2 hands on the chest. As far as where I put it, so I'm gonna be on the upper chest. So if we talk the upper chest is anywhere between like nipple line to the clavicles, I'm somewhere in that range. My hands are gonna be at a diagonal because my direction of force, if we know the upper chest moves in which primary planes? Superior and anterior, yep. So, so I know that my force is gonna be going like in order to facilitate going more posterior and inferior in direction. I can also add a little bit of medial to kind of cue in pecs a little bit, just with the direction of where the pecs are, okay? Heels of my hand are not really doing anything. I should not have pressure here, or else I think Billy would be really uncomfortable if I push on his clavicles, right? So really my hands are just resting there, and it's my fingertips that are gonna be more direction of the push, okay? So same thing here, I'm just gonna follow his breathing. Anyone see any movement at anterior chest? No. I got nothing. I'm not moving at all. I'm curious to see what kind of happens here, right? In. And out. Breathe in. And out. Breathe in. And out. Breathe in. And out. So my direction of force is coming down and in. It's also getting a stretch to the intercostals, or a quick stretch to the intercostals to kind of cue them to expand and to move the rib cage up. So that would be one way to kind of move upper chest. If I'm not having a lot of success in this position, I might have to actually put him in a different position, because I'm not really feeling, after we've done some rib cage mobility to see does he have the mobility there, try this technique. Then I could try using a towel roll, and then I'll actually put him in sitting next and then see if that changes. The other hand position, so if I can be here and pulling in this direction, I could come to the side and I could use one hand technique, okay? So if I'm here and I want the rib cage to come up, good. That's the direction my hand's gonna go, and back down. Good, so I pull it down and in, up, and back down, up, and down. So my hands don't actually come up. I will start to lift the pinky side up, and that whole concept we talked about taking up the slack would come in here. So as he breathes out, I'm going to follow him all the way down, and then that's when I add my quick stretch there as I move forward. So why would I choose one hand over the other? It might do my hand side versus his trunk size. It might just do that this feels uncomfortable for the patient to have me right on top of them. They might be really small, and so I can't really get 2 hands. Like a younger child, you can't get 2 hands on the rib cage and have it really work. But let me also try you up and sitting. So if you want to see that Billy just needs more extension, is that comfortable? Okay. So if I have him kind of lean back here, and we can try the same technique to see, can we get a little bit more of a rib cage? Good, good. Breathe in. And out. Breathe in. So a little louder voice to see, can you kind of tap into those fast twitch muscles versus that slow, low voice used before. Good. Breathe in. And out. Breathe in. And out. So I felt a little bit more there. I don't know what you felt. Which was better?
Yeah, agreed.
Okay. Weird. Okay. So let's say I was going to have Alex do some reaching here, and I could, right? I could come in and I could facilitate distally, like to work on a reach. But let's say I want to work on rib cage mobility too. So I could come in here. So I'm going to ask you to reach up here. Ready? So reach up. Good. And then back down to the other knee, cross knee. Good. Bring up. Good. And back down. Bring up. So I could add this technique to something functional like reaching. If I really wanted to get, let's say he's got the shoulder range, but I don't get that rib cage expansion that I need to actually make the shoulder more functional to reach, I could go here and facilitate. So that's just like a little bonus, extra thing you can do. Thank
Would
you.
that be a way to get more expansion on the right side in the upper chest?
Yep.
Just
Yep. So if by doing, so I'm imposing mobility now, like of the arm. So I want to time that trunk expand or that rib cage expansion with the arm coming up. So that's just another place that you could facilitate from, kind of bring it into function. Okay. And probably the biggest thing to keep in mind is like, who would I use this on? Why do I need it? Where does this kind of fall in overall patient management? So if you look here and it talks about all the different, with airway clearance, okay, because we're kind of entering the airway clearance section. So everyone told me in the last lab that everything looked familiar in here, right? Okay, good. Nothing should be new. But this would be a way to think about like, where are we intervening in the airway clearance? So they have to have a way to get secretions up, right? So they have to get it to those parts of the lungs that they can actually then mobilize and cough out. We are going to intervene in just the expectoration. So assistive cough techniques fall in there. There's other things that fall in there too. So, and then once they actually cough it up, if I'm making someone cough because they need to, or we've rolled on the mat and they have to, I want to make sure they have something to do with those secretions when they come up. So what are your three choices? Not as the PT, but as the patient. You would spit it out, swallow it, or suction. So I want to make sure I've asked them, like, how do you, when you cough, what happens? Do you spit? Do I need a suction machine? What do I need? So I have to know what I need in my PT space or area before I actually get them moving, because chances are, especially in acute care, people are going to be adjusting and needing some help with pulmonary management. Okay? So keep in mind, you always have to ask that question. If I'm going to ask you cough, I want to make sure I know what you're going to do with it. What do I need? Okay. All right, so moving on, we're going to go to, there are 4 assistive cough techniques we're going to go through. One of them, the Heimlich, we're going to talk about the hand positions and how to go through it, but we're not going to do it on each other, because that's just not nice. And plus, we all have abdominals, and the minute you went to cough, you just pop someone's hands right off, and it becomes ineffective. To your position, you can be supine, sitting, or side lying. I teach this in supine because I think it's a little bit easier. What's the problem if we're asking someone to cough when they're in supine?
Gravity is not your friend.
Yeah, gravity is not your friend. So recognize that you're going to probably have to act more quickly with secretion management, especially if they choose just to spit or drool. They can't really do that in this position. So you can also do it in side lying, and I like it a lot in sitting, but I'm gonna demo it here. Okay. So it's going to look a lot like the rib cage mobilizations that we did. So hands are going to be on the side of the rib cage. And I'm going to be the pressure, I'm going to work for a pressure generator, okay? So I have to work the 4 phases of cough. So the article talked about it. So the 4 phases of cough.
Deep inhalation.
Knowing I have to have those 4 phases, I know I have to get maximum inspiration. I think I mentioned in a lecture 60% of vital capacity in order to actually generate enough force for a cough. So I have to have them take a deep enough breath in. So I might have to facilitate them taking a deep enough breath in. That's the first thing. The second thing is before that, I have to explain to the patient what I'm going to do, so I'm going to do that in a second. I have to make sure they take a deep enough breath in, so facilitating that. And then I have to give cues as far as timing goes. So I know they're going to have to hold and have some pressure, okay? And so I'm going to give that cue, I want you to hold, and then I'm going to make some artificial to build up the pressure by doing a little bit of squeeze before I actually do a forceful cough, okay? So I'll go through one cycle, and then, without me talking to you, and then I'll go through it one more time and kind of tell you more of the nuancy points, okay? Okay, so what we're going to do today is we're going to do a technique called costophrenic. I'm going to put my hands on the side of your rib cage, and I'm going to have you breathe for 3 times.
Okay.
And on the 3rd breath in, I'm going to ask you to hold it. I'm going to start to do a little bit of squeezing, and then when I tell you to turn and cough, I want you to turn that way and cough as hard as you can.
Okay.
Okay? All right. So let's just do 2 times. Okay. Okay. So you don't know. Right?
Yeah.
Right. Breathe in. This is 1, and out. 2, breathe in. Sorry, one more time. Good. Breathe in, hold, turn and cough. Okay. So some of the things that I did there, I did a little bit of a quick stretch. I took up the slack to help her take a deep enough breath in. On my last one, when I told her on this one we're going to go, I did a technique where I did a couple different compressions. Who remembers what facilitation technique that is? Okay, so I used repeated contractions, and so what I did is that I'll pull down, let go, pull down, let go, pull down, let go. And the idea of that is to keep the muscles engaged throughout the whole breath cycle. I don't always have to use that. I could just ask her to take a deep breath in, hold, turn, and cough. So that's one thing I added. The second thing is, as we did, she held it, right before I asked her to turn and cough, I started to squeeze and come in. So I was pulling down and squeezing in, increasing the pressure. And then when she turned and coughed, I was holding that there, and I held it until she was all done coughing. If I were to let go, then she loses all the force, or she loses all that pressure. Okay? The habit of going, you can't really, if you're going really fast, you can't say in, it doesn't work. So it helps with your timing of the contractions. So when in doubt, talk, because it helps with your timing. Okay? Any other cleanup questions?
I just practice it.
It's practice.
This totally is timing. It's one of those that takes practice doing.
Yep.
Ben had I thought was an interesting question, which instead of telling them when to cough, do you ever just tell them at the top when you feel like it's the time to cough, turn and cough? Just because you feel when you have to cough. But if you're just holding it, I don't know, do you always cue them to cough when you think they should cough, or do you ever let them, I guess they can't always feel it is maybe the thing. I don't know.
So you would do this technique because someone has secretions, right? And so you can hear the secretions, and you can hear, so deep breathing is going to help mobilize the secretions a little bit. So you'll start to hear them come to those upper airways, and then I put on the 3 cycles of breathing, or else you just breathe all day long, and then there'd be no secretions because you don't have any. So a lot of times you're saying, we're just going to do some deep breathing, and I'm going to listen for those secretions. And then I'm going to tell them, all right, we're going to do 2 more breaths, because you hear them, and the patient will sometimes nod and know that they need to. And you'll see them start to cough a little bit. And that's when you say, okay, 1 more breath, and then we're going to take a deep breath in, and then we're going to cough.
Okay.
So
I think the directions get you on the same page with the patient versus waiting for them. I'm just going to, I'm going to build this pressure, they're going to cough whenever they want. I think verbalizing it just makes sure you're both kind of doing it together, if that makes sense.
your chest compression.
It's a good point.
Okay, so the Heimlich is as it sounds, is I'm going to be underneath the rib cage. I'm going to use the heel of my hand, and I'm off midline. What would happen if I was just straight midline and pushing up? It would feel pretty horrible.
And you're going to have some other outline.
Yeah, or if I do this, if this is my go-to airway clearance strategy, they'll end up with some type of reflex or just general discomfort, So I'm going to be off midline, and I really can't facilitate breathing in on this one. This isn't a timing thing. And Karen, I know a lot more of your families use this in sitting.
They do.
In wheelchair, and it's more of an emergency kind of thing.
It is.
There's a kid has a lot of secretions trying to cough, maybe they're out in the community, they don't have all the tools that they need at that moment, and it's we need to clear this, or someone's in sitting and choking, and this is another technique, and they're not strong enough to cough it out because they don't have the abs, or they have just generalized weakness. Okay, so I'm not going to really do breathing cycles, so as I see the air kind of gets into trouble, I'm going to go underneath the rib cage, so I'm going to really go down and up. So this is my direction of pull. I'm actually underneath here, and I'm pushing forcefully up towards the head. I don't know if you have anything else you want to correct with that, what you see. Yeah.
Just with kids, it doesn't take much force.
Yeah, so kids, you don't have to press as hard. With us, if we were to do this, we have innervated abs that when we were to do it, our hands get kind of pushed out. But for people who really have abdominal weakness, you can really go right underneath there and just forcefully push. And it really is a quick thrust. Okay, so that would be a Heimlich for somebody who doesn't have like control of abs to actually get a cough out. Okay, that's the first one. And the second one is going to be anterior chest compression. So this is a technique where, let's say I'm doing the costophrenic cough assist technique. This would be an alternative to it. So let's say either I can't really get good handholds on the rib cage, or my hands aren't strong enough, and I wanted to go to a cough technique where I can use my forearms here. This would be an alternative to this. I remember Judy gave another example in my ab. I'm gonna think about it for the other patient. That's would be. So one hand, one forearm is going to be kind of right above the nipple line, and the other one is going to come right underneath the ribs. So I'm kind of on that interim, like I'm well below the xiphoid. I'm kind of right parallel, just right at the umbilicus. And so the idea of this cough is that I can facilitate taking a deep breath in. I can still do all the phases of cough. So I'm going to ask him to take a deep breath in, hold, turn, and cough. That's still going to be the same. The difference is I'm going to be able to be on two parts of the rib cage. So I'm going to be upper chest, and I'm going to be just underneath the lower ribs. So my pull is going to be down and in for coughing, and you'll actually see someone kind of flex up. And this can be a really effective cough technique. As far as facilitation, it's impossible to use both arms to facilitate, because with breathing in, you don't get simultaneous belly and chest rise, right? So you have to pick one hand to facilitate with, and we're going to do upper chest. It's really, I would argue, kind of futile to try to do abdominal facilitation with this. So, but with Eric, what I can do is I can try to get him to breathe up, and I can still just take up the slack and do, I'm going downward and inward for the upper chest to facilitate breathing in. When I'm going to ask him to hold, I'm going to start to compress down and in on both sides, and when he goes to cough, I'm going to squeeze together. Okay? I'm not going to do that much force through stomach, so I'll do a little bit more in your upper chest. Okay, so I'd explain to the patient, be like, we're going to go through this cough assist technique. I'm going to have one of each of my arms, one on your chest and one on your stomach. I'm going to try to get you to breathe with your upper chest a little bit more, but we're going to breathe for 3 times. On the third trial, I'm going to ask you to hold it, I'm going to squeeze, and I'm going to ask you to turn and cough. Okay? Okay. Good. Take a deep breath in and out. That's 1. Breath in and out. Last one. Ready? Breathe in, hold, turn and cough. Okay. So here I asked him to hold. I started to squeeze a little bit, and then it's really more of a peck squeeze with a little bit of downward pressure. Okay? So I'll do one more time. Okay, ready? So 3 breaths. Breath in and out. Breathe in and out. Last one. Breathe in, hold, turn and cough. Okay. So as I ask him to hold, as he's holding, I start to squeeze a little bit. When I ask him to turn and cough, then I do a little bit more forceful down and in. Okay. So would you use this with someone who has a really unstable rib cage? No. So if someone really has like a pectus excavatum or something like that, where they have a lot of hypermobility, or you get a lot of collapse in the rib cage, I would not use this technique, because I don't want to accentuate that. I would choose to probably do more of the costophrenic. Okay? All right, I'm just here and facilitating. It should be light hands. And it's really only when I get to the cough do I add the force. Okay? So when in doubt, go light, and then do a little harder if it doesn't work. Okay, so this is technically assistive cough technique. This is the only technique you can do with someone who's in a coma. Okay? Yeah, no one has to follow a direction or anything. Okay? You don't even have to time breathing or coughing or anything. What I usually see it used for is that a patient who, like, pretty significant brain injury. Brain injury is going to be what I'm going to go for because that's the only population I've really used it with. But if they're kind of that Rancho 2, Rancho 3, I can do some general mobilization, like just gross range of motion. So I'm going to use like a rotation technique that can pair breathing with movement. The other thing it's nice it does is as I'm kind of here and I'm doing some rotation, if someone has a lot of spasticity or tone, what do you think this would, think it would help it or hurt it? It would help it, yeah. You're kind of doing rotations. You get someone to relax a little bit. The other time I would try to do this is someone who has a really high respiratory rate and I'm trying to get them to relax, okay? So the technique is going to use, it's counter rotation. So I'm going to have two hand positions that are going to slide. I have to slide because my hands are small. If you have bigger hands, maybe you don't have to slide, but I do. So the general idea is as I move in this direction, as I'm pulling away, I'm going to pair inhalation with this. So I'm going to be pulling here. My point of contact is going to be on the scapula with one hand here, kind of pulling up and forward. I'm going to be on the ASIS, grabbing it and kind of pulling down and back. Okay? It's not straight rotation, it's on a diagonal. My position is by the pelvis so that I can really be in that plane of movement that I have. If I'm straight on, then this turns into just a spinal rotation, right? But if I position myself here, line and pull, I can get this. So we're here, we're going to breathe in. I'm going to slide my hands, posterior fossa, and then anterior shoulder, and then out. Breathe in and out. Now I could model some breathing, and I could try to see if we could eventually have the same breathing pattern. If I breathe, if she really had a high respiratory rate and I breathe at the same rate, I'd probably pass out, right? But could I try to influence that by just relaxing to kind of get her in a normal breathing pattern? If I'm doing this for tone inhibition or something, and then I start to hear a lot of secretions, I could then add an assistive cough component to it. So if I'm coming out here, breathe in, and breathe in. You weren't expecting that.
Nope.
Right? And a cough. Now, what phase of cough am I not getting here? Pressure. Yeah. So what's the cough technique you guys learned where you actually don't have to have vocal closure? Vocal fold closure. More of a huff. It's going to be more of a huff cough. And this is really going to be something where I'm doing this anyway, and I could add a little bit of force to it to get kind of that. I can get some pressure, but it's not going to be enough. But it's enough to kind of get a little bit of a cough. What's nice is she's in sideline, so if she has secretions, she's just going to drool it out, maybe. Or maybe I need some suctioning, something like that. But it's just a really nice technique there. So just to kind of go, I'll go through a whole cycle so you can kind of see what it looks like. Right? So kind of just following first. Okay, now I'm going to add a compression. So the nice thing here too is as I'm compressing, I'm kind of getting all three planes of movement of the rib cage. So I'm getting compression, right? I'm getting a little bit of rotation for the rib cage. So I really am getting in multiple planes of movement to really be most effective, okay? Some things, things you don't want to see. If I'm doing this and all of a sudden I see her face, I know I'm rotating her back. I should not see that. I should only see the profile of her face. That's a therapist error in how I'm pulling, but I really should be more in this direction. Her head should not move. If you're seeing a bunch of this, then you're just pulling the wrong way. Okay? All right, let's have everyone give it a shot. And then if you can, and he's breathing in, and he's breathing out, breathing in.
Sorry.
It's gonna be more quick. If I exhale, so think about it. If I have him inhale all the way and I start to slowly exhale him, and at the very end I do a compression. I lost all of that inspiratory capacity that he had. So I want to get as much inspiratory capacity as I can and then force it out. and that's going to be more effective. Does that make sense as far as timing? Okay. So, thank you. This might come up. Yes, fine. Okay, this might come up for a patient who's doing a self-stretching program. They're in prone. They have a cough or something like this, and they're here anyway, and you can teach them how can you be more effective in actually to get a cough out. So we talked about some patients who are in prone can have anxiety with breathing. Why would that be? Yep. You block the abdominal excursion. Yep. And so this can be hard. So I wouldn't throw a patient in prone and be like, I'm going to teach you how to cough in this position. They have to be okay with being in prone first. That's like a prerequisite, right? You've worked in prone, you're doing prone walk-arounds, you're doing a lot of strengthening in prone, and then when they tolerate this position, you could use this cough technique. So phases of cough still apply. So what is the first thing we have to ask them to do? Inhale. Yep, and we talk about ventilatory strategies. If I'm asking them to inhale, which way is their eyes and their head moving? Up. Yep, up and back. You still need to have pressure generated. Okay? So the technique is going to be, I want you to look up, and then it's going to be a forceful head. Don't do it yet. It's going to be a forceful head throw forward. I don't want anybody to whiplash for repetitive head throwing. So it's going to be take a deep breath in. I want you to look up, take a deep breath in, and you have to initiate the throw before you start to cough. Why? What happens if I cough as I'm throwing my head? Besides you'll like spit over everybody. That's hygiene. But
The down is the creating pressure, so you have the pressure created before you cough.
yep, so it's the same thing as when we did costophrenic and we started to artificially squeeze and help build up that pressure before we asked them to actually cough. It's the same thing. So the cues can be, I want you to take a deep breath in, look up, throw, then cough. So they should be initiating the cough when their head is down at the table. Okay, so this is a timing issue. Okay, because we don't ever hyperventilate. So just take like 1 or 2 cycles and practice it, actually do it, and then switch people.
And throw your head down, throw it down.
And it has, so this long sit technique, so someone as high as C3 could do this technique if you prop them or place them in long sitting. So imagine you're working with somebody, they're higher cervical level injury, you're just placing them because they don't have any way to artificially lock their elbows, so you kind of place them in that, like stacking them in long sitting, and then they start to have some secretions or need to cough. This is where this technique would come in, okay? So we'll do just leaving arms propped for the first time. The second round we'll do is when we actually throw the arms. So for those that have really tight hamstrings, you might want to at that point ring sit. Yeah, when we get there. Okay. So same ventilatory strategy. So if I want to maximize inhalation, so what's my cue going to be when they're in long sitting? Head up, look up. Yep, and then it's going to be a throw, and if you can internally rotate your shoulders, great. Yeah, and it's going to be a turn and throw. The same thing is that you're going to throw your head, generate that pressure, and then cough. There you go. Nice. For this, if you want to do ring sit, because we're going to throw you forward. So PTs, if you're PT, you're going to be the thrower. Okay? So same thing's going to apply. If your arms are back, you're still going to look up and breathe in. As you go forward, you throw the arms and your trunk forward. Okay? So PTs can either, and it's arms throw, not I'm going to arms place them. You're going to throw. So as a PT, you can either help forward flex them, you can help get the arms to throw, or you can help duck the head. Whatever you feel like you'd like to help with.
Okay, I'm just going to give you a shove, all right?
For a patient, so imagine a patient sitting in a wheelchair. They could be as high as C5, C6. You can, if you have some kind of biceps, you can still do this. So just like we had the Heimlich when we were in supine, you kind of have to get up and under, so under the rib cage and up along here. You can do the same thing. So if you take your hands midline and you use just your biceps, you can still, and if you come forward, so if you throw your head forward, do a forceful forward flexion and squeeze it in. Because we have abs, the minute we cough, our hands pop out, but patients don't, right? Or central cord impairment, and so they were able to walk, but they didn't have really good hand function. And so this would be an episode of choking. Not necessarily, it's more airway clearance than cough management, but the idea that you could fold over some type of surface in order to clear. Has anyone seen that technique before? Yeah.
The one they teach you when you're babysitting, in the babysitting course, if you choke, you can't go to sleep.
Oh yeah, over a chair. Yeah, so the idea that a patient who has that kind of impairment, they might be able to throw themselves forward, but they probably can't get back up. So at this point, they're probably calling 911, but at least they're alive. So the last one is going to be hands and knees. So some on hands and knees on the plan. Last one. We still have all of those same techniques we have to use. So we still need eyes up, breathe in, coming forward as far as you can. So chances are a patient who's using this has, like let's say we're talking spinal cord, what level could you do 4-pointed?
T-ish somewhere.
Sure. So you probably don't have, so if you lean too far forward, what's going to happen? Yeah, you're just going to fake. You don't have control over your hips. So you want to come as far forward as you can, but actually still have control of your hips. Okay? And what's going to happen? Eyes up, head up, breathe in. And then the same thing, you have to go through forward flexion before you actually start to cough. And you should go all the way to and forcefully pull back. Yep.
Nice.
They get that one.
And your buddy comes along.
So, and when people cough, you're really coughing into the surface, into your legs. If you feel like, as a therapist, if you stand in front of the patient and they're coughing on you, they're not coughing at the right time. So that should be the cue. You should cough into your lap, or you could, pull back, sit back. So now, if you're a PT, where are you going to help?
At the hips.
You can do it at the hips, yes. If they need help with the forceful back, if they need help just taking a deep breath in,